Have you ever walked into a clinic, explained how you're feeling, and left with a label that felt like it only captured half the story? Or worse, the wrong one entirely? You're not alone. The world of mental health is full of stories like this. Stories where people are misheard, misunderstood, and misdiagnosed, not because the clinicians didn't care, but because the system is built on shaky ground, where bias and noise cloud every decision. Let's start with a young woman named Sarah, a bright 22-year-old who recently started college. She was struggling with energy, motivation, and sleep. One psychiatrist labeled it as depression. Another thought it was bipolar disorder. A third said ADHD. Same symptoms, 3 different diagnoses. Why? Because even in our most scientific systems, human judgment is messy. Mental health isn't like a broken bone, where an X-ray gives a clear answer. It's like trying to measure fog. And the tools we use, checklists, interviews, even rating scales, are all filtered through human perception, which is inherently flawed. Enter bias. Confirmation bias makes a clinician see only what they expect to see. Anchoring bias leads them to stick with the first impression. Availability bias means they might overdiagnose what they recently saw a lot of, like calling every sad person depressed during the pandemic. But it's not just bias. Noise is the other silent culprit. 2 equally qualified psychologists can assess the same patient and give completely different diagnoses. Daniel Kahneman, a Nobel Prize-winning psychologist, wrote an entire book about this called Noise. His team found that even when professionals use structured tools, there's still shocking variability in decision-making. This is especially true in mental health, where symptoms overlap, fluctuate, and present differently based on age, culture, trauma, even gender. For example, boys with trauma are often misdiagnosed as having conduct disorder, while girls with ADHD are often labeled anxious or just emotional. The system wasn't built to capture nuance. It was built for speed. In America, most mental health evaluations last 15 to 30 minutes. That's like reading 1 page of a book and pretending you know the whole story. But how did we get here? Part of it is capitalism. Clinics are rewarded for throughput, not thoughtfulness. Insurance codes prioritize checkboxes over context. There's also a cultural obsession with diagnosis, as if putting a name to the pain is enough to cure it. But labels without understanding can be dangerous. John, a 35-year-old software engineer, was labeled as having high-functioning autism because he struggled with eye contact and preferred working alone. But no one asked about his childhood. If they had, they'd learn he grew up in a violent household and used emotional detachment as survival. His autism was actually complex PTSD. Trauma wears many disguises, and when you don't ask the right questions, you miss the truth. It's not that diagnoses are useless. They can guide treatment, validate experience, and help with access to services. But they are not truths carved in stone. They are hypotheses, approximations, educated guesses at best. And in a system full of noise and bias, we must hold our labels lightly. Think about this. A study published in JAMA Psychiatry found that diagnostic agreement among psychiatrists for schizophrenia was only around 60%. That means 4 out of 10 patients could walk into a different clinic and walk out with a different diagnosis. Imagine that happening in cardiology or oncology. And yet, we build entire treatment plans on this unstable foundation. Now let's talk about culture. A Black teenager expressing anger is more likely to be seen as oppositional, while a white teenager might be seen as depressed. Asian patients often minimize symptoms due to stigma and end up underdiagnosed. Latin families may describe depression in physical terms, like fatigue or pain, and clinicians unfamiliar with this may miss the signs entirely. Mental health is deeply cultural, and yet we apply the same Western labels and DSM categories everywhere. It's like using one map for every terrain. It just doesn't work. Then there's the gender lens. Women are more likely to be labeled with personality disorders. Men are more likely to be labeled with substance use. But what if both are coping with the same root issue, childhood neglect, abuse, attachment trauma, but expressing it differently? The same tree, just different branches. And then there's the epidemic of over-medication. In the absence of time and nuance, pills become the shortcut. But many medications were approved based on short-term trials, not long-term outcomes. And they often target symptoms, not causes. A child acting out might be given stimulants, but what if he's reacting to domestic violence? A woman with panic attacks might be given benzos, but what if she's in an emotionally abusive relationship? Medication can be life-saving, but it can also be misused when it replaces curiosity. We need better tools, yes, but more importantly, we need better questions. And we need systems that allow us to ask them. Technology might help. AI tools can reduce some noise by analyzing patterns across large datasets. For example, voice-based intake systems can capture more history than rushed interviews. Measurement-based care, where we track symptoms over time using validated scales, can provide more objectivity. But even the best technology won't fix bias if we don't train clinicians to recognize their own blind spots. Bias is not a moral failure. It's a cognitive reality. We all have it. The question is, are we willing to slow down and reflect? The future of mental health must be multi-layered, biological, psychological, social, and spiritual. We can't reduce people to scores. We must restore the art of listening, the power of context, and the humility to say, I don't know. Let me learn more. Because mental health isn't a checklist. It's a story. And every story deserves to be told in full. We need systems that honor the complexity of human pain. We need second opinions, multidisciplinary teams, and time. We need to empower patients with their own data and stories. We need to bring narrative medicine into psychiatry and trauma-informed care into every clinic. And above all, we need to remember that every diagnosis is a beginning, not a conclusion. Sarah, John, and millions like them are not broken. They are survivors of a system that needs healing just as much as they do. This is not just about psychiatry, it's about humanity. When we silence the noise, confront the bias, and choose to listen deeply, only then can we begin to truly see each other.